Okay. How can I run the show here by this one? Okay. My patient is a 54-year-old male who presented to my clinic with recurring chest pain. For that, I diagnosed him as unstable angina. The issue is that this guy had a PCI and they aim to continue more with PCI later for his multivessel disease 2 months before. So the LAD was left circumflex were approached and dilated and stented and then discharged. But the patient did not feel well, continued to have chest pain, knowing that also he had uncontrolled diabetes. He's somehow non-compliant, also hypertensive and dyslipidemic. I did the dobutamine stress echo, although I did not have to, only to convince the insurance that we have to do him. Otherwise, the insurance would not have approved. His echo was normal. ECG showed some T-wave changes and septal cues. This is his right coronary artery. I only have this brief shot. It's basically totally occluded proximally. This is his left coronary system. There is a mid-LCX stent and a mid-LAD stent. But you notice before the proximal LAD stent, there is a lesion, and distal to the stent, there is another lesion, and there is distal to the left circumflex a diseased segment. And this is the right coronary artery filling retrogradely. So I decided to fix the LAD of what's left of the LAD, because really it was not clear to me what is the cause of his unstable syndrome. It cannot be the totally occluded vessel. So I decided to dilate distal to the stent and treat it with drug-eluting balloon. And the treatment went well. Then I decided to treat the proximal LAD, and I positioned a stent directly and dilated it. Again, no issues. Post-dilated, and the result was satisfactory. Then I went to the left circumflex and did the distal to the stent segment, again with the intention to put a drug-eluting balloon. And that also went well. Finally, I decided to tackle my RCA because here I still have to solve additional large area of ischemia. And I crossed with the Gaia 2, but with extreme difficulty. Then when I found myself way into it, I said, okay, but I'm not sure. I cannot see any flow distal to the vessel. I put a microcatheter and I double-checked. It turned out that I'm in the right place. So I repositioned another wire, which is a Pilot 50, and started doing what we usually do. Start with the smallest balloon we have and try to cross the segment of interest. But none of the balloons would cross. After the second balloon, which is 1.5 only, you could see the leakage around the spot. I'm not sure if I can hold it. You see, it's a little bit of dye leakage, so I suspected there is a problem. So I here was in a dilemma what to do, whether I should continue or not. Regardless, whatever I want to do is to make sure that I will cross. Now I have a little issue. So I put this balloon, which is a 2-millimeter balloon, okay, this is the 2-millimeter balloon, but big mistake. What I did, I made it much worse. Now I have no crossing ability. The balloon made my initially leakage into a big perforation, and I had to deal with it. So I just bought time by putting a balloon proximal to the occlusion and gave myself some time to think. So what should I do? If you want to help me here, I can entertain with you what should we do. The question is, this is a failure to cross with balloons from the smallest to the middle-sized, and already there is a perforation at the site. Now, of course, the first step is to block the vessel and then think about what is the next step. Strategically, what you want is either to quit after securing that the balloon will seal the occlusion, or proceed with a methodology that will help you cross the uncrossable. So these are the options, anywhere from crossing by any means to keeping the blocked flow until it seals and quit the procedure. So here I decided, no, I cannot do that. First, this is, unfortunately, there is one missing video that shows that I re-blocked the art vessel for 16 minutes, but after the dilatation, I ended up with the same leakage. Maybe a little less, but certainly not comfortable. So now I cannot cross, but the wire is well into the lumen of the distal runoff of the vessel. So the only way is to secure crossing by any means. It came to me a couple of ideas. First, to use a guide liner, but my previous experiences with the guide liners in a situation like this is terrible. Usually they don't help. The use of a shock wave also will not help because it will not reach the totally occluded segment. And the only chance of success is to cross with a burr, with a rotablation. Now, what it meant also that I could easily make the perforation worse. And that was my concern. But again, if I made it worse, but I secured the road to the end of the vessel, then at least I can put a coated stent, a covered stent. So this was my first burr. And this is my second burr, and it managed to go beautifully throughout. And now it's the surprise. No more bleeding, no more perforations. And I have a good runoff, but it's an atypical type of RCA because where the wire is actually in the PDA, in the PLV branch, which is high takeoff, and the other segment without. So I decided to treat the PLV branch without stenting. So I put a drug-eluting balloon because my target was to fix the entire rest of the RCA. And I put a very long stent, typical of my friend's stent that he used, a 50 millimeter though, tapered stent. And it gave me some good result here. You will see post-dilatations. And that was the final. So to me, what I saw is the following, that I did cause a perforation to the mid-RCA, no doubt about it. And I did the echoes to make sure that the patient is stable, and he was. I thought of every possible venue that I should select in order to fix it. Anyway, the plan was to stop flow by all means and to avoid tamponade, of course. The echo at the site that helped me to tell me that there's not much of any leakage into the pericardium. Crossing the calcified lesion then becomes a priority. Advancing a balloon using a guide liner would have been an idea worth trying but not guaranteed. Using shockwave balloon also would not likely to be successful. What happened that the Rotablator allowed crossing, but the mechanism by which it facilitated sealing of the perforation remained to me unclear. I found many reports about Rotablator causing perforations, but I have not seen a report Rotablator sealing a perforation. Thank you.
Thank you. Thank you very much, Dr.